Okay. Good afternoon, everybody. My name is Jahan Corbin, and this is my friend and fellow breast cancer survivor, Lynn Haddad, and we are your host for BRA Banter today. We're really excited. We're going to be talking to an expert in the radiology field about breast screening and have the opportunity to ask some questions that come up a lot with breast cancer survivors and patients. We are members of an organization called Breast Cancer Recovery in Action. BRA is our acronym, so you can insert your supportive pun here. We are primarily located in Middle Tennessee, but we actually have 11 groups all over the state and also in Florida. And our organization serves women to connect them with other members of the breast cancer community. We first and foremost primarily are a community, and we look to provide resources that will be helpful and beneficial during and after treatment. And it could be while you're going through treatment or 20 years post. We meet people all along the way, wherever they are in their journey, primarily through 3 E's of programming. We have exercise twice a week with a pink ribbon certified trainer. We have emotional wellness, which is a small group setting where you have a safe place to process the emotions that come along with a breast cancer diagnosis and work through a curriculum in a safe space. And then also education. And that under that umbrella includes things like BRA Banter, what we're doing today. Excuse me, I'm gonna have to cough.
It's the season.
Got something stuck in my throat, excuse me. So with that, if you're interested in learning more about BRA and what we do, all of our resources are free to the community, and we would love to have you participate and hopefully be a resource to you as you're going through this, because we have been there. And it's always nice to have somebody who's a little further down the road walk alongside with you when you're going through something. So if you're interested, I encourage you to please go to our website, BRA Groups, BRA Groups, GROUPS.org, and you can find more information. With that, I'm going to turn it over to Lynn to introduce our speaker today.
Yes, thank you very much. I am so pleased to be able to introduce you all to Iantha Allton. That's Dr. Iantha Allton. Some of you may recognize her by her former name, Dr. Iantha Harney. Iantha has been affiliated with several local hospitals, Williamson Medical Center, the Center for Breast Health at St. Thomas, and Premier Radiology throughout her career of almost 20 years. So thank you very much for taking time out of your busy schedule to join us today.
My pleasure.
We always like to, those of you, are you okay?
Sorry.
If Jahan passes out next to me.
I apologize. Spring
allergy
allergies
season here in Middle Tennessee. We always like to ask our BRA Banter guests, for those of you who watched Banters in the past, for a fun fact to get us kicked off. And so we reached out to Iantha for a fun fact, and she told us that her name actually comes from her great-grandmother, and it's Greek in origin, but your family is not Greek in origin, is that correct?
That's right. It's one of those names that was not quite as uncommon 150 years ago, but it never got that resurgence in popularity that some other names get.
I think it's a really special story. I love it. My real name is Evelyn, and it's also a family name. And so I think it's kind of a cool origin story. So thanks for sharing that with us. All right, so Jahan gets the pleasure of asking you your first question.
That's right. And I will just say that as a person with an unusual name, Jahan, I always appreciate hearing what somebody else's unusual name, their story is. Iantha shared with us before we started recording today that she is getting married in a couple of months. She's at a very exciting time of her life. And I was thinking, before I heard the piece of the fun fact that your family is actually not Greek, I was immediately thinking of my big fat Greek wedding when I heard your name, and then I thought about the old movie. So that kind of dates me, but if you know that movie. Okay, so we're glad you're here. Thank you for joining us. Would love to hear just kind of what brought you into the world of radiology. What interested you about it? How did you end up into in this field?
Well, when I was in medical school, I was kind of searching for where I thought what specialty I might be attracted to. And I had initially thought I wanted something that was very hands-on with patients, that there would be lots of doctor-patient relationship and interaction. And when I actually started rotating through the different services, I was really attracted to radiology, and partly because my first degree is engineering, and radiology really is that intersection of medicine and technology. When I started learning breast imaging as part of my training, what I found is that there is an area of radiology that still it is very much involved with the doctor-patient relationship and the doctor-patient interactions, and still a very clinical service. And so it became sort of a natural fit.
That's interesting. When I think of radiology, I don't usually think of it as having so much patient interaction.
Right. Even most doctors don't. I had some of my mentors who were frustrated that I was going into radiology. They said, "But you're so good with patients. You shouldn't do radiology." They imagined me sitting in a dark closet by myself talking to a computer. And there are some radiologists that's what their day looks like. But breast imaging is much different in a couple of ways that I think we'll be touching on.
Yeah, I love the way you described it as the medicine combined with technology. That's a really great, is that what you said? Did I
Yeah, yeah, it
intersection of
is.
medicine and
Yeah.
technology? I
Yeah.
love that. That's a really good way to think about what all you're doing.
Mm-hmm.
Interesting. Okay, so moving on to our next question. Could you help explain to us a little bit about the difference between diagnostic and interventional radiology? We have members who, hearing that they're going to have mammograms per se, there's a big difference, right, between a diagnostic mammogram and interventional radiology, right? Big change in what it means, I think.
Yeah,
I need
and part of what you're
I'm
touching
not
on,
sure I understand this, so I need to learn more about this topic.
sure, sure. And one of the things that you're touching on that is a common source of confusion is the difference between screening and diagnostic.
Right, yes.
Okay. So anytime we are screening patients for disease of any type, it could be breast cancer, it could be diabetes, it doesn't, of any type. What we do is we have a test that is affordable enough that we can use it for everyone, right? And we're applying it to pretty much all comers or everyone who it makes sense for. They meet whatever criteria for the screening. And then what we're looking for is any kind of indication that this patient may have something going on and it requires more evaluation. So that screening test does not necessarily result in a diagnosis. One screening test for, prostate cancer, for instance, does not immediately mean that there is a cancer diagnosis afterwards. It means that this patient needs evaluation. And this is how we gather up those patients who otherwise would not be diagnosed until later in the course of their disease. Because I myself am a big believer in early detection. The gains that have been made in breast cancer treatment and outcomes has everything in the world to do with early detection. And so we want to try to screen as many women that are above the age of 40 that we possibly can, right? Now, so ideally every woman age 40 and above is coming in for their screening mammogram. If something comes up on the mammogram, that does not mean there's a diagnosis of cancer, right? There are a lot of things that can show up on that mammogram that are not cancer. What it means is we need to look further. So when they come in for us to look further, that is a diagnostic evaluation. Now we have reason to look more closely. And we will use the tools in our toolbox a little bit differently. The approach is a little bit different for your members that have been through that experience. They go in for their regular annual, they may get a couple of images and they leave, and they just don't hear anything for a few days. During the diagnostic evaluation, they may still have a mammogram, but it's actually a different approach. We're using that same tool a little differently. And we might also wind up using ultrasound, physical exam, biopsy, a lot of other tools in the toolbox. So this becomes very confusing when if we think of breast imaging or mammography as just preventive care or just being screening. It's not. There's a first step that is screening. There's a segment of it that's screening, but there's also the diagnostic part, and that gets treated differently. The appointment is different. The level of expectation that you can have of your visit is different. Now we have to have an order from your physician. You cannot self-refer for that. This is going to be directed by the radiologist. Even if you don't see the radiologist during the visit, every step of that evaluation is being carefully supervised and evaluated real time by the radiologist. So it's a very different approach for screening and diagnostic. Now, interventional basically is referring to, in our world, mostly biopsies, right? And if you look at general radiology, if you look at the other parts of the body, maybe the liver, the lung, things like that, the interventional procedures are mostly going to be concentrated in the hands of radiologists that really specialize in procedures. A little different in breast imaging. In the world of breast care and breast imaging, the doctors that are doing the evaluation of the images are very likely the same doctors that are actually doing the biopsies. And so the evaluation of the images, the biopsy kind of becomes a one-stop shop, right? You don't get sent necessarily to a totally different radiologist or, and that becomes important when we get into some of the most advanced procedures that we do.
Interesting. So in our population, right, there's people who are, new, who have never been in the women's population, I guess, let me step in, right?
Sure.
There's your first time people who have never been diagnosed with cancer. And then there's the people that Tahan and I are interacting with daily who have already had a cancer diagnosis, right? That's why they're. Do you feel like maybe, they're being screened more carefully? Because I feel like a lot of us have more trauma from our diagnoses, right? So these medical appointments are very stressful. And so when they get to the level of that diagnostic screening, it's very stressful. But I think also because we've already had a diagnosis, we're being watched more carefully, right? So it seems like they might be ending up in the diagnostic screening pool more frequently because we're being watched more carefully, but it's also bringing so much stress. Is that the area where you were interacting with patients and found that you could be of assistance? Because
definitely.
I found like it's very stressful, and I can remember so many times like I've spent a lot of times in the dark little room, like reading for information, and it's a bad feeling.
It feels like forever, doesn't it?
Yeah, especially once you've already gone through something like that.
The second time you're there, it's not good. It's just, and I appreciate the care that is being extended to me, but man, it's a rough day. Anytime you get that call back or you have to go a little bit longer for more pictures, it's a level of stress I can't quite explain. Like I get nervous just talking about it. It's
right. And it is definitely, there's a different approach. First of all, most women after a diagnosis, probably surgery, maybe or maybe not chemotherapy or radiation, after all of their treatment, most patients are going to be followed with a diagnostic mammogram for the first couple of years. Okay. Not because we're looking necessarily, expecting that we're going to find something more, but what we're looking for are those subtle changes. And so in those first couple of years, there is going to be close scrutiny. And so it'll be a diagnostic mammogram because we are doing a higher level of scrutiny than your typical screening mammogram, which is going to be somebody that has no recent clinical concerns. Okay. And we are more likely to do additional images during that mammogram. So you see them start pulling out tools that you haven't seen before. You're like, why are we doing extra views? Why are we doing more pictures? Well, that's actually standard for our patients that have recently been treated. And so that is should be reassuring.
Yeah.
But you wouldn't know that if you
Anybody
don't.
watching this,
Yeah, that's
don't
helpful.
freak out.
That's helpful.
It's
It is.
okay.
Yes, yes. As soon as that extra tool comes out, they're like, why?
What's
You know,
happening? Yeah.
but no, just by the fact that you have recently been treated, you are going to be under a higher level of scrutiny.
Right.
And that whole evaluation again is going to be supervised by the radiologist real time while you're there.
Mhm.
And in a lot of cases, you'll have a result before you leave. That's not always true. I don't want to make that promise, and I don't want to give anybody a level of expectation, but
Right.
in my hands, typically patients would have a result before they leave. Now they may be leaving me and going right next door to the breast surgeon, right?
Right.
For many years, I worked right next door to Dr. Laura Baskin. She was an
Mhm.
excellent breast surgeon. And so I may actually be on the phone with Dr. Baskin while the patient's getting dressed. So their appointment is right down the hall. So their appointment with me and with her is kind of combined. We're on the phone discussing things before, like kind of real time. And
Right.
so, but certainly like before they leave and to go home, they'll probably have some sort of indication. Um, the and even like years later, if your treatment was 10 years ago, at this point, we can actually see you for a regular screening mammogram. You don't necessarily have to have a diagnostic. It doesn't necessarily have to be a real-time evaluation by the radiologist. And so a lot of times those patients will come in, get their regular standard views and leave. What's missing is they may not necessarily get immediate feedback either, right?
Right.
Now you've got to wait for the letter. But also in our culture in the breast centers, a lot of times the technologists will pause and call us and say, she's a cancer survivor. Do you mind taking a look at this now or real time? Or she was wondering if she could get something before she leaves. And if we can, we're happy to do that because compassion. Because
Human component,
Mhm.
you understand how that would feel to someone,
Yeah.
right?
Right.
That's,
I've told the technologist for years that suspense has no place in breast imaging. Okay.
yeah.
Suspense is for like reality shows. Use that for American Idol.
Movies, exactly.
Right. That's great. But we do not enjoy suspense
Right.
when it comes to breast health. And so we try to and when I go in to see patients, if I'm going in to do an ultrasound, you know, if I've decided that everything looks okay and I want to come in and talk to the patient, we all have a different threshold for when or why we may come in to talk to a patient.
Mhm.
Unfortunately, I think a lot of people think, oh, the doctor came in the room, it must be something bad. It's not necessarily. It's not necessarily. Sometimes, like, my technologist gets wonderful images, but I can see a little bit better real time if I do the ultrasound myself.
Yeah.
Or maybe I want a little bit more information. I want to come talk to the patient. But what I do is when I walk in the room, I'll say, hi, everything looks fine. And I'll say that immediately, right? Because she's holding her breath. And I
Yes.
know that, right? And so then we can talk. And now I can ask the questions and all that. But I try to end the suspense just as soon as I can. And if we do need to talk about a biopsy, we will. But if we don't need to talk about that, I really try to just as soon as possible. Hello, I'm Dr. Allton. Pleased to meet you. Your images are fine. Let's take a look together, and just let her exhale. So,
Right. Yeah, that's so
Yeah.
important. That's so
yeah.
important. Well, you mentioned several times the breast tools, the breast health tools that y'all use. And I know, even having been through this process and having like the mammogram, the biopsy, the ultrasound, the MRI, I've done a lot of those through my breast cancer experience and just through other things, through other injuries I've had in my life. But I still get confused on what's what and what can see what. And so I'd love for you, if you don't mind, talking a little bit more about those tools and the differences and how y'all utilize them.
Sure, yeah. So the physics behind each of those tools, or we call them modalities, is very different. And the physics is different. The way that we can utilize it is different. And this has all been heavily studied, heavily evaluated, right? So a mammogram is X-ray, okay? Just like you might X-ray a broken bone. But it is a very high detailed X-ray. Okay, we're looking for very small, subtle changes. And that is particularly good for things like microcalcifications. We've all heard of microcalcifications, okay? But it also can find things like masses and things like that, okay? The important thing to know about mammography is that that's our main tool for screening. Screening mammography is the cornerstone of breast imaging, regardless of your history, regardless of, kind of the approach, put it that way. For anybody over age 40, especially. And if we're doing an evaluation for symptoms, even for patients over age 30. Okay. So when patients say they don't want a mammogram, but I can use other tools in the toolbox, like you would never say that to your mechanic, right? You would not say that to your heart surgeon.
Right.
And I think that there is a lot of misinformation or mistrust about mammography.
Mm.
The amount of radiation exposure from a mammogram is extremely low. You probably, if I got in a plane in Nashville and flew to Denver, I would probably get more radiation exposure in my breasts than I do for my annual mammogram. It is extremely low, and it is a tool that we use very carefully. But considering what we're looking for and what the stakes are, mammography is considered a very good tool despite the radiation. And so I want to reassure your members, and I try to reassure all of my own patients that the amount of radiation exposure coming from a mammogram is really minimal, and it is very, very carefully utilized.
Is that a concern that you hear a lot? Because I don't, I
No.
never thought about that.
I would never
But
consider
I,
turning
you
down a
obviously
mammogram.
have heard that before. How often do you feel like people come in wanting to know about the radiation piece?
Frequently.
Really?
Is
And the
it
thing is,
younger
you know
or-
what, I understand concerns. I think that, yeah, if they have questions, those are excellent questions for us to talk about. However, I truly would reassure them, and this goes back to my training in engineering, what I know about physics. A third of my board certification in radiology is just physics and understanding how radiation interacts with the cells in our body. Okay. So when a YouTube influencer is telling people, oh, don't let them do a mammogram, it's radiation,
Mm,
Wow.
then that is not serving our patients well
right.
at all.
Good information.
It's fair to ask.
Makes
It's
sense.
absolutely fair to ask the question, but I do want to give that reassurance.
Yeah, of
Okay?
course.
And one of the problems is that we often will have patients who come in who want to approach their breast imaging like it's a cafeteria. I'll take this, but not that, right? You would not do that to your heart surgeon, right? You're going to let them use the tools that they need to do the best job for you that they possibly can. And if you have any understanding of the level of education and care that is taken and how we utilize those tools, I think patients would be very reassured. I really do. But yes, that is not an uncommon barrier for some patients. So basically mammography is X-ray, very low dose X-ray. Okay. And it is absolutely necessary in what we do day to day for almost every patient. Okay. Ultrasound is utilizing sound waves. And then MRI is very different. MRI utilizes radio frequency. So the detector in the MRI is actually an antenna. Okay. And this is actually looking at, on a level of physics, the electron spin of the the molecules, the atoms that are in the cells of your body. Okay. So it is a fascinating, very complex physics that goes behind MRI.
Mhm.
The part that's important for patients, when we get away from the engineer and get back to the medicine, okay, MRI is mostly looking at the way that the blood flows. MRI is a type of imaging of blood flow in the tissues. Okay. So when we're looking for cancer, cancers cause the vessels around them to be leaky, and the vessels that are inside of the tumors are leaky. And so MRI is actually utilized to look for different areas of blood flow. And so what you'll realize is that every modality has completely different physics behind it. They
Right.
look at the tissue in completely different ways. They are not interchangeable.
Mhm.
No.
And so one of the things about ultrasound, for instance, is that I tell patients with an ultrasound beam, when I have the probe in my hand, it is almost like going into a completely dark room, completely blacked out, and I'm looking for something and I have a flashlight. And I can see anything in the room where I point my flashlight, but only where I point it. Okay. And that's kind of a way of thinking of ultrasound. When they're putting it against your skin, they can see the tissue between the skin and the chest wall, but nothing else. MRI can be like walking into the room and flipping on the light switch.
Mm.
MRI looks at all the tissue from your collarbone to your waist. It can see tissue all the way, to your spine sometimes, or at least to the level of the heart. So I can see tissue on an MRI that I cannot see with mammography or ultrasound, but I see it in a totally different way. And what we do as a radiologist is it's kind of like having a picture puzzle, right? I have to take all these different pieces of information, put them together sort of like a picture puzzle, right? To really get a picture of everything that's going on, not just in space, but also what are the characteristics on mammogram and what are the characteristics on ultrasound. I might have a cancer on a mammogram that can look just like a cyst, for instance. So you would never want to say, okay, well, we'll do a mammogram, but we won't do an ultrasound. No, this is where ultrasound has a role, because an ultrasound can help me tell if it's a fluid-filled cyst or if it's something solid.
Mhm.
Very important, right? I could
Very.
look at that. If it's solid, I can maybe look at it under MRI and look at the blood flow. And maybe I can tell, yes, it's a solid mass and it's benign.
Mhm.
Or I can say it's a solid mass and it looks like it's going to be malignant.
Mhm.
So each modality can have an important role in one case evaluation for
Right.
one patient.
Can I ask a question about, like, now I've heard, and I don't know if this is true, this is just what I've, that like MRIs have a higher rate of false positives? Would that,
Right, right.
what is it about this imaging of the blood flow that would cause like a false positive?
Well, part of it is that we're looking for areas that have extra blood flow or extra fast blood flow. Blood
Oh,
flows in and blood flows out more
right.
quickly. Tumor can do that, but so can inflammation,
Oh, okay.
right? So other things can do that. So you're going to combine the anatomy, which you can see on the MRI,
Mhm.
with the areas of blood flow and really how that's distributed. Is it one oval area of blood flow or is it multiple small little dots of blood flow, right? These are the patterns that we're looking for. These are my pieces of the puzzle I'm trying to put together, right?
Mhm.
But the truth is that every modality has some false positives and some false negatives. And that's why we spend so many years training to learn how to use these tools in the toolbox to compensate for each other's strengths and weaknesses. Okay. So breast MRI, one of the things that you may be thinking of is that breast MRI is also being evaluated for both screening as well as diagnostic evaluation, right? There are some patients out there that breast MRI is appropriate for screening. And remember at the beginning, we talked about how screening is people who don't have any symptoms, but they meet the criteria for screening. So this may be somebody who has the BRCA mutation, for instance. Okay, so for high-risk patients, screening breast MRI may be appropriate, okay? But it's not for everybody.
Right.
Partly because if you're not high risk, if you're a normal level of risk, like someone like myself, then it has to do with something called pretest probability, but it's not the best tool for screening. It's not even an appropriate tool for
Right.
screening because I'm going to find way more false alarms in
Right.
normal risk people with MRI than I am cancers.
Yeah.
Maybe
Yeah.
not more of them, well, more of them, but also the balance is not there. It does not make sense for, just normal risk people. So when we think about using something like MRI or even ultrasound for, supplemental screening for those patients that are high risk,
Right.
we have to know how to use that tool and use it appropriately. Again, not for people of normal or average risk. And partly because we have to be able to balance what's the possibility of a false alarm. It's a double-edged sword in a way, right? I tell patients we love MRI because it'll find every little thing.
Right.
Yeah.
Problem is it'll
We
find
hate it
every
when people
little.
find every little thing.
There is an emotion.
And
There
we
is.
can, we can start chasing our own tail, trying to hunt every one of them down. And now I saw that one little dot and I don't have anything that matches on the mammogram. I don't have anything that matches on the ultrasound. What am I going to do with this one little dot? Am I going to watch it? Am I going to biopsy it? Am I going to put her through, how far are we willing to take it? Well, that's why we have to make sure we know when and where to use those tools.
The MRI, and I don't want to get too deep in the woods here, but I know you just loving the background and the science. MRI is magnetic waves, right? Magnetic waves.
Right, right.
Okay.
Well, it has to do, it is a strong magnet. The machine itself, it has a very strong magnet, and that magnet is on all the time. And that is why patients should be, undressed. They should be completely, you don't want patients to even be wearing their own jewelry, for instance.
Right. Nothing but metal. Right.
Yeah.
Yeah.
Right.
Okay.
So,
I was curious. I had somebody a tech recently. We were talking about CT scans versus MRIs. This wasn't about on the chest area, just another part of the body. But she was telling me that with the popularity of Lululemon leggings, like how many
yes.
young women are wearing Lululemon leggings, that they actually have some kind of metal particle that they use in their leggings, and it was causing problems with the MRI.
Right.
They didn't have a zipper or.
Yeah, they didn't have an obvious metal part, but
it's in
it was
there.
affected. It was in there.
Well,
Yes.
and it's not entirely benign. There was, I saw an example recently of someone who was wearing like sweatpants and it had a drawstring, and the drawstring had a little metal thread through it to make it stronger.
Uh-huh.
The patient was burned.
Oh
Because
no.
what happens is that
Right.
little metal thread,
It gets
in the
hot.
setting of what happens inside the machine, a current started flowing through that metal thread and it heated up and it burned the patient. So it's not benign.
Right. No.
And that's what it's a safety concern.
Right.
Even for minor things in our clothes, and certainly for anything larger, there have been stories of patients who decided that they just weren't going to inform the technologist that they had a gun.
Oh my.
And that they absolutely could have been killed, but then they start moving them into the MRI machine and that gun starts moving, and that could have been absolutely disastrous. So, this is really an area where cooperation is very much an issue of safety.
Yeah, I would think
seriously.
so. Did we talk about thermography? I don't think.
I don't think so.
I think that is in our pre-conversation, you had mentioned that is, so I mean, I think we know as breast cancer survivors that we are a market that is frequently targeted for scams. Everybody seems to want to make a buck off us. So I feel like this is maybe one of the areas where people are looking for easy money from breast cancer survivors. Is that basically what I remember from our conversation?
Maybe. I mean, I can't really speak to the motivation
Okay,
of the people who are doing or selling those.
all right, fair enough.
But I will tell you that the concept of thermography is the idea that a tumor that is getting more blood flow will be warmer.
It's not
There's a
science.
logic, right? There's a logic to that.
Okay,
I
right,
will tell you that for that to happen, it would have to be of a size that this should not be a screening evaluation. That mass would have to be large enough that the patient or her physician should be able to feel that. And if the patient is getting regular breast exams, they should be sent to me for an immediate diagnostic evaluation, right? So that would not be that they're not going to be picking up little tumors by temperature. Okay. Thermography was the idea of it seems logical enough. It was actually evaluated by the radiology community many years ago. They tried to look into that. The thing is, nobody really likes mammography. I don't like having my mammogram, right? It's not comfortable.
price isn't awesome.
No.
Yeah, it's not perfect, right? So we are always trying to evaluate every technology, every tool in the toolbox. Could this be the thing that replaces mammography, right? And we keep running into the answer no. And mammography cannot be replaced. It really cannot be excluded from breast care. So it was quickly determined years ago that thermography was not going to be a valid tool in the toolbox, and radiology discarded pursuing that. Okay. So I'm not trained to read a thermogram. That is not part of my training. The
Right,
thing is that those machines still exist, and there are companies that still make them and that still sell them. And then they find people who are willing to set up a shop to perform them and and to give those to patients. The thing is that it's whatever misgivings it is that leads patients uh, to pursue alternate options, right? Alternatives to mammography or your radiologist as your primary diagnostician,
right,
basically. Whatever it is that persuades patients that maybe this is a great idea, this is a good alternative, are often just misguided. Okay. I would, if that was a good tool, I would use it, right? Every tool that will help me to take care of my patients, all of the above. I'm not going to exclude any tool if it is accurate, if it is valid. If you
right.
ever look at one of those reports that comes from thermography, it'll say on there, this should not be used for diagnostic purposes.
Yeah,
Okay, there is more typing on that report that is disclaimers because they're not taking responsibility for your health with this. In some ways, they're basically telling you that we're doing this almost for entertainment purposes, right?
well, do insurance companies pay for thermography?
No,
So, I mean,
because they are not going to pay for something.
Yeah.
Yeah, it's not valid. It's not valid in diagnostic.
that's why I kind of look at it as a money making, I mean.
Exactly. Right. In my most ungenerous moments, scam might be a word that I would use to
Right,
describe that. But the truth is, I have talked to some clinicians, that for one lady, I think she's a very good chiropractor. She cares very much about her patients. But when an equipment rep comes to her and tells her, oh, patients with dense tissue should not have mammograms, it's not valid for them. They need to have this instead. Could she maybe be persuaded that this is a good idea? It's not that
not
maybe
intentionally trying to do something wrong, but she's not maybe doing
right.
diligent, is what I would
I
say.
really would blame the equipment manufacturers. I think that they should know better. I really do. But because I don't think that in anyone's hands, I don't think thermography has a role. And so when patients bring me their thermography report and say, here, something came up, I want you to evaluate it, they may as well bring me their horoscope,
Right.
right? I'm not trained to read that. I don't utilize that. And that really isn't going to have a role. I don't have a way to incorporate that into my evaluation. Now I will do a full evaluation about any concern that they have,
I
but
has nothing.
understand that it's kind of like, and you know, you'll hear stories about somebody had something that was detected on there and it turned out to be real. But that's just like saying that, you know, my Apple Watch picked up an arrhythmia, and then when I went to my cardiologist, they found that I have an arrhythmia. That
Right.
can maybe happen, but the truth is that no cardiologist is going to take an Apple Watch and say, well, there it is, there's the diagnosis. What they're going to do is they're going to do an EKG, right? They're going to do
Right.
they're going to do a true full evaluation with their tools in their toolbox. And that's
Right.
sort of the same thing.
Yeah, that's a great explanation.
Okay.
Okay, number 3. This is the
Okay.
third question we're gonna throw out.
All right. So this has come up, and this is actually something that has come up with me. So a tumor presents as one size on mammogram, one size on MRI, one size on ultrasound. Now we talked about that there are different types, right, of tests using different forms of engineering
Mhm.
to evaluate the tumor. But
Right.
that can cause a lot of confusion in the patient, right? Because you're like, well, okay, so if they all are working properly, even if they're different types of modality, shouldn't they at least be coming up with similar numbers? And so I had a large triple negative tumor, and the mammogram had one number, and they were all just different, like really by like 2 centimeters. I mean, it was very disturbing. We're like, well, what is it? You know, I need to know, you know, it's upsetting. And
Mhm.
so, do you have, and we are actually, I'll just tell you, running a little long on time, but do you
Sure.
have any thoughts that you can offer our members and our audience about why this would happen and that it's not that the tests aren't working properly?
Yeah, I mean, I can reassure you that that is not uncommon, and we know that, we understand that. And so we kind of already know, like, what modality we think is going to be most accurate to establish size and things like that. And one of the things is that a mammogram is basically, you know, it's an X-ray. You know, we kind of think of it in terms of shadows, okay, in a way, and all of the tissue is superimposed on itself when we do a mammogram, right? The whole breast is in the mammogram machine at the same time, so it's all overlapping. So that's
Right.
one thing, right? So, like for example, I have a water bottle, right? So if I'm trying to measure my water bottle and I show this to you, how tall is the water bottle?
Yeah.
It's hard to know, right?
No
It's
idea.
all there. You can see the whole thing, but it's
Right.
overlapping. The height of it is overlapping because of the projection, right?
Uh-huh.
So that kind of thing is part of it. The way that the tissue will overlap on itself and what is the orientation of the
Right.
mass when we look on the mammogram. So with ultrasound, especially in a large tumor, it's irregularly shaped,
Yeah.
right? So if I said, okay, you have a small flashlight in a very dark room, and a small flashlight,
Mhm.
and I have something irregularly shaped like a chair. What is the measurement of the chair? I need you to go measure it. You can only see a small part of it at a time, right? Now, this is an extreme example, but a reasonable one for our purposes. So you can sometimes think, I probably see one end to the other in this image. You know, also you're doing it in slices with ultrasound, okay? And so the way that it's measured, right, is, are you going to measure it from the top? Or are you going to measure it from the corner? Are you going to measure it from the tip? Are you, you know, and it's irregularly shaped. So that you can see how there may be some variation in measurement depending on exactly how you measure it. Also, think about the way that the breast tissue is oriented when you have your mammogram. The tissue is pulled off the chest wall and flattened, right? Think about how the breast tissue is positioned when we do an ultrasound. Now you're laying down and it's spread over the chest wall and flattened in a totally different dimension, right? So we are always, the radiologist is always trying to say, how did this look and where was it oriented on the mammogram and where do I expect to find it on ultrasound? MRI, again, we have totally different position of the tissue, right? Now you're laying, leaning forward and the breast tissue is hanging by gravity. It's pendulous. It's kind of held still, but it's not really compressed to the same degree, right? So now it has that three-dimensional kind of like a cone, shape. And so we went from taking something that's squishy, squishing it this way, then we squish it this way, and now we have it not squished.
Right.
And also remember that MRI is going to be like flipping on the light, right? So now I can see that chair that I wanted to measure as an example. I can see the whole thing. I can see which one is the longest dimension. I can see, does it make sense to me to measure from the corner or just from the edge, right? And so that's part of it, is just the way that we actually can see the size and shape of it, but also MRI is picking up the blood flow, right? That's why MRI has that mammography and ultrasound generally don't. We can see some features about flow, but not the same. We're seeing, this is about blood flow imaging. And
Right.
so we can get some details with the MRI that we're not going to get with the others. And that's part of why the measurements can seem different.
Yeah.
And, and also that irregular shape, some masses are going to be shaped like a snowball kind of,
Right.
and some of them are going to be shaped more like, a spider web.
Right.
Like,
Mine was
how
like,
do you measure a spider web?
everybody pictures it being this perfect pea or whatever on it, but no, it wasn't.
No, it often is not. And there are some tumor types, and I think most of us know that there are different types of breast cancer, different types of, the genetics matters. And there are some of them that will grow through the breast,
Right.
like single file cells, like a spider web. And it's only after they've grown through that tissue for several centimeters that they'll actually start to sort of contract on themselves and create a mass. Well, by the time we find that, it's just harder to find, right? So by the time we find that, it's already kind of, so where are you going to measure? Are you going to measure the mass, or are you going to measure those threads that have gone out into the tissue, right? And so we won't see those threads into the tissue maybe until we get to MRI.
Right.
And so this is where the different tools in the toolbox, and the one of the best values of MRI is going to be surgical planning.
Right.
Right? The breast surgeon needs to know if there are threads extending into the tissue. The breast surgeon needs to know if there are little satellite foci. And that's really where we make a difference.
So MRI is the most likely,
Is
probably
considered the most accurate.
real sizing and probably staging as well, right?
Right. Now, really the most accurate would be pathology, right?
Yeah.
When they take it out and they slice it and they measure from cell to cell. But a lot of people now are getting neoadjuvant chemotherapy.
Well, that's what,
So
yeah.
you can't, we don't get a final measurement from pathology. So now we're relying on radiology to give us that, how big do we think it was at its largest, right?
Yeah. And
So
to
interesting.
determine the staging.
Yeah, fascinating stuff.
Excellent.
Great. Okay, so we're gonna wrap up shortly here, but I think our last question that we discussed was something that I hear a lot about, and I personally don't have any experience with it, but we hear women talk about, for years they've been told that they have dense breast tissue. And so could you elaborate a little bit on what that means and how that, well, what the implications of that are when you're looking for potentially something cancerous in the breast?
Sure. So dense breast tissue is important, and the thing is that dense breast tissue, what it means to me as a radiologist, is what your tissue looks like on a mammogram. That's it. Okay. So sometimes I will have patients come to me and they'll say, well, I had a physical exam and the nurse told me that I have dense tissue. Okay, well, that may be true, but until you've had your first mammogram, we don't necessarily know if it's dense tissue in terms of what it means to a radiologist. It may be that to them, the texture of the breast tissue seemed a little bit dense. That's not dense tissue in terms of what we discuss in radiology. Okay. So everybody has the same type of tissue in the breast, right? We all have the glandular tissue, the ligaments that support the tissue, the fat cells, the fat tissue that kind of cushions between the skin and the glandular tissue. We all have very different proportion of how much of that is in there, and we have different proportion of how it's distributed in there. Okay. So I have some patients that will have, the ligaments are going to be very thick and fibrous. The glandular tissue is very plump and very abundant. Okay. And then there are some patients like myself that, the breast tissue, it looks like mostly fat, and it just looks like a small little island of glandular tissue up in the corner. There's as much variety in the mammogram as there is in how we appear, on physical exam, right? And there are some trends, yes, on physical exam that, you can start to predict, like this patient is probably going to have a dense mammogram, right? But I wouldn't diagnose them as dense breasts until I see a mammogram personally, okay? So we all have the same type of tissue. We have different proportions, sometimes dramatically. And it changes over time. It changes from when you're in your 20s through your lifetime. It changes significantly when your hormonal status changes. So either with menopause, or if you have surgical menopause, like have your ovaries removed, it would change. And we can see a change if somebody starts their hormone replacement. We can actually see it fluctuate. Okay. So it's not just a fixed thing necessarily. It changes over time. A little bit. But the reason it's important, two things. Number one, the patients who have the densest category, 4 categories according to the American College of Radiology, and it's those most dense, that's only going to be about 10% of patients, have tissue that is dense enough that they actually are going to have a higher risk of breast cancer than average. So that's important. Okay, very important. One of the things that's most important to me as a radiologist is that not only is she at higher risk, she deserves more scrutiny, right? But it's going to be harder to see a breast cancer because everything I'm looking for on a mammogram is white. And that what we call dense breast tissue is the proportion of white tissue to the dark gray. The fat tissue is dark gray, but the glandular tissue, the vessels, the ligaments, those are all white. And so if you have very white tissue and I'm looking for something white, it can be like trying to find a polar bear in a blizzard. Okay. And so the reason that the legislation has come out and the reason that came about is because patients realized that for someone like myself, who has predominantly fatty tissue, just a little bit of white in one little corner, even a small early cancer be a lot easier to find in my breast than it would in someone who has very, very dense tissue all the way throughout her breast. Small early cancer can absolutely be hidden in that tissue. So for these patients, physical exam needs to be emphasized. Breast self-exam needs to be emphasized, right? And then we need to also think about, are there appropriate imaging tools that we need to use for supplemental imaging? So if you look at the breast, the legislation, if you look at the letters, right, there was, what we're referring to is that many states, and now I think at the federal level, there are laws saying if somebody has dense breast tissue, you need to tell her. People need to be aware, right? Part of that is because the level of reassurance that the dense patient is going to get is not the same as the level of reassurance that I'm going to get. But also it's trying to trigger the patient, make them aware to know that supplemental screening measures should be considered. Those supplemental screening measures don't all have to be imaging. I would suggest first starting with good thorough breast self-exam and clinical breast exam. It's a great place to start. And really, the most appropriate additional imaging is adding tomosynthesis, that 3D technology, into the mammograms. Now, that is widely available. That has really become very standard and common and widely available. That if I knew that I had dense breast tissue when I had my mammogram, I would definitely be asking, is this going to be a 3D mammogram?
Okay. That's great information to have. And I think, knowledge is power. I mean,
Yeah.
so for someone who does have dense tissue to know it, to be vigilant about, like you said, the self-exams, talking to your doctor about it and really understanding more about that is so helpful. That really
Well,
explains
that
a
is
lot
it,
for me.
because the law tells you to get a letter, which I have gotten letters before I had breast cancer, but it doesn't tell you what to do with this
What to do it,
information.
right.
Right.
And to
What
me,
they
that
tell
would
you
have
is
been
to
a
talk to your doctor, right? I mean, that's
Right,
really
and
kind of
so it's like,
the,
okay,
yeah.
thanks. But yeah, that's the piece that honestly should have been
The
part of
information
it,
that you
but
needed.
yeah.
Part of the problem with that is that the laws, or coming out with the legislation to require that those letters go out, those are laws that were written by people who are not breast imagers,
Right.
right? And a lot of times those laws that are made that have to do with breast care don't include any breast specialists,
Right.
Mhm.
Well, you don't want to
right?
scare people. I get that. There has to be a happy medium, but yeah, a little more. Please talk to your doctor about it.
Right, right.
That would've been-
Well, and the other problem is that those laws were made and those letters started going out without necessarily having answered through our own science and research what
Best.
is the best next step for those patients. And so now you have the doctors, your OBGYN, your primary care doctor, they have patients start showing up with these dense breast letters, and they've had to learn what is the appropriate next step. And I'll just, I know we're going to be ending soon, but let me make a plug for breast self-exam.
Okay,
Okay,
please
go
do.
for it.
Please do.
And I tell you, it works better than you'd think. It really does. I talk to patients all the time, and of course sometimes they'll roll their eyes like, this is no shame. If you're not doing it, I understand. It's hard to know what you're looking for, right? We tell patients to feel around and look for a lump. Well, we forget to tell them that breasts are lumpy. So they're like, well, there's a lump and there's a lump, and what do I do with that? And oh my God, and so they either think I must have cancer everywhere, or, I mean, it's like, how would they know? And I mean, I've been doing breast exams for over 20 years, if you include my training, right? And I will tell you, it took a long time for me to feel like I was getting really good at it. Like doctors have to learn, there's a learning curve for it. So my answer to that is this: a woman has to know her own body. You have to know your own tissue, because the best and first expert is going to be yourself. When a patient comes to me and says, I don't know, something's just a little different, my antennas are up. Okay. If it's, sometimes they'll say it's just a little thicker, or maybe the tissue doesn't move the same, or why does one nipple look a little lower than the other now, or the contours change. Sometimes it can be subtle things that patients will pick up. Sometimes it's not subtle, right? Sometimes it's a mass. Sometimes it feels like something in there. This is really challenging for patients that have cysts, because they will get lumps that come and go, because cysts can kind of come and go. But this is where I say people have to get to know their own tissue, because it probably will be different. You're looking for a change from before, or it's different maybe than the other lumps or bumps. And really, when it comes down to it, you don't have to be the one to figure out if it's okay or not okay. You just find it and bring it to me, and I'll tell you,
That's right.
Something is different.
Better to
and
be
get
safe
in.
than sorry, because you know that something feels
Absolutely.
different to yourself. And you're really inspiring me. I have a teenage daughter. You're really reminding me the importance of, I need to be teaching her how important it is to get in this habit of doing that and
Yeah.
make sure that she's taking care of herself.
Yeah. Yeah, you have to know your own tissue and don't be,
Absolutely.
don't be shy. It can be, you can start in the shower. Some people will find things better when their hand is slippery with soap or in their shower. Some people, can find it better, laying down on the bed and just, put that arm up, really spread that tissue over the chest wall, and you use the other hand to feel around. Um, I mean, for me, I can be watching TV at night. I'll just
Yeah, just wherever. Yeah.
make sure my stepchildren aren't in the room, pay attention, right? But
Right.
when I'm alone, I'll,
Yeah.
and I'm looking for, I mean, just the point is to do it. Looking for
Right. That's
something
right.
that's any different than before. I myself have gone in twice to be evaluated for changes in my breast tissue or new lumps, and I got reassurance,
Right.
goodness, but I I don't even as much time as I've spent doing breast exams, I don't expect that I'm going to be able to tell.
Right.
All you have to do is find it. What to do with it, we'll take care of that.
Right.
Yeah.
Let me ask you this about the monthly self-exams. Is there truth to doing it certain times of the month, like around the time a woman has her cycle or when she's ovulating? Is there any benefit to doing it at a certain point during the month?
Is, yeah. So some of the things that the thing is that breast tissue is really rather dynamic. They're not just sitting there, right? I mean, we kind of think of them as being kind of just static and maybe, you know, um,
Ornamental.
unless we're lactating. Say what?
You said ornamental.
Ornamental. I've used that term. I have actually used that term. I
Arms.
resisted.
Alex.
Absolutely. We do though, right? But we don't think of them as being it's really very sensitive tissue. That tissue reacts quite a bit to environmental factors, what your hormonal status, right? So where you are in your monthly cycle, if you have monthly cycles, that matters. It responds to even environmental factors like what you eat, right? Like, have you ever eaten sushi? Felt a little bit fuller after that, Um, and so, and especially for patients that deal with fibrocystic disease, and that's a whole other topic of its own, but that tissue can be very reactive. And so, yes, the breast tissue changes quite a bit, based on just the normal monthly fluctuations. For women who still are having periods, that is kind of probably the most likely thing that is going to affect that breast tissue in a dynamic way month to month. So I will tell you, like a couple of years ago, I had my mammogram done and I just fit it in when I could. And I didn't pay attention to my cycle when I was still having cycles. And I went in there like right before my period, like an amateur. And I was like, I knew better. I mean, I was sore for a few days, I just
No.
didn't think about it,
Yeah.
and it was fine. I mean, you can still do that, fit it in where you can for sure, just get it done. But it was, I had to laugh at myself, like I knew better, Part of the nice thing about doing it at the same time, relative to your cycle is you kind of want apples to apples, right? Because I said we want to look for something that's different from before.
Mhm.
Yeah.
So you kind of want to compare it at the same point of your cycle from your previous, right? And so that, so things may feel more full or more tender if you're at a different point in your cycle. So you just want to, it helps to sort of normalize it.
Sometimes you gotta just take the appointment though.
Yeah, right, you gotta
Absolutely,
do it,
absolutely.
right? You gotta fit it in.
I think that's
The more
all
important
the
thing is to
story.
just
Get
do
it
it,
done.
just get it done, right?
Get
Yeah.
it done. And a lot of places now you can schedule it online.
Yeah.
Yeah.
A lot
Yeah.
of places have appointments for screening mammography outside of 8 to 5.
Yeah.
That's nice. Yeah.
That's
Okay. So those are, they really try, even sometimes on Saturdays, they really do try to lower those barriers so we could just get in there and get it done.
Yeah.
Thank you.
Which I so appreciate
Great
that.
points.
Those are fantastic. Thank you so much. This has been
Been wonderful.
very
I
informative.
have learned so much and
I
I
have too.
thought with the amount of screenings I had that I knew more than I
Agreed,
knew.
but I learned a lot. This has been wonderful, and
Yes.
we're so appreciative of your time and your expertise, and the fact that you're willing to share it with us today. So, a huge thank you to you.
Yes.
Thank you so much.
My pleasure.
listen to the experts and get it done.
That's right.
It's not YouTube.
That's right.
Experts. And keep up to date with all of your screens.
If you're a
Please,
personal
it
friend of
really
mine,
matters.
you will get a text from me on October the 1st, because
Yeah.
I text everyone I know
Mhm.
on October 1st, and I'm like, if you haven't done your mammogram this year, I need you to do it right now or make the
Yeah.
appointment. So,
You know,
all right,
you
I
you
appreciate
wanted,
Thank you
those
for-
appointments are easier to get in January.
Yeah,
All right.
you're probably right. Yeah,
Pick 'em up.
I think about it. You're right.
Pick any
Okay,
one.
All right.
thank you
have
so
a wonderful
much.
day.
Take care.
You're welcome. Bye-bye.